Hi, I'm Dr. Rik here. I'm with the Integrated Body Center in Hastings, and we've organized to put together a little presentation about hormone optimization. And a lot of people are curious about this, and it's a very timely topic. Here I have the October National Geographic, interesting article about the tigers in India, by the way. But if you open it to the middle article, it's titled Older, Better, Faster, Stronger. And the first sentence is, in evolutionary terms, humans are pretty new at getting old. Since 1900, we've managed to increase our life expectancy from 47 to 78. Isn't that amazing to think that basically nature just wanted us to reproduce and then get off the planet and leave the food for the next generation. But now we're living so much longer that we're starting to have troubles that nature never thought would come up because we're aging past that time. So I'm very curious about hormone optimization, and I should tell you a couple of stories about it. I was coming at it from the perspective of working in a place that was doing Botox and filler and a lot of aesthetics laser stuff. And I noticed that some of my longer term patients would suddenly just need a lot more of the laser or the filler or something changed. And when I asked more and more people about it, it was menopause. They had hit menopause and it started to lose more elasticity in their skin. And then I thought, well, I wonder if we can do anything about this. So I looked into estrogen creams for the skin, it doesn't work. And I looked into other hormone replacement stuff. And I was brought up doing my regular doctor work in an era when we were told all sorts of stuff that wasn't accurate about hormone replacement. And I had to learn new research since then that has shown all about the safety. But I'll get into that. So what brought me in was the skin. And then the second thing that happened was, this may seem strange, but I'm a heart patient, and we heart patients, more than anybody else, really needs to do exercise, really needs to do cardio. I mean, if I don't do cardio, I die, like not figuratively, I will die. So I noticed that as I was in my 52 era, 53, that I would exercise and I would be so achy, sore, and tired after exercise that I would have to wait about 3 days to exercise again. And I could never make any gains. I was always losing. I was losing muscle. I was trying so hard to do this, but I couldn't exercise frequently enough and hard enough to be able to maintain the gains that I'd had. And then I started getting on hormone optimization, and then I was able to exercise and recover in a day, and exercise again and recover in a day. And I was able to get on a much better regimen. I was able to get off one of my blood pressure pills. I feel like that is one of the things that's going to keep me alive, is being able to do the exercise because of hormone optimization. So that's just background about why I'm curious about this. But as most of us know, hormones affect everything. I mean, if anybody who's been pregnant or been on prednisone knows that when your hormones shift, a whole bunch of stuff shifts, whether it's the skin or your mood or your sleep or your everything. And a lot of what we're talking about here is affecting people who are between 40 and 60 years old. That's when there's a lot of shifting going on, kind of dramatically in women. We used to think that menopause was when the periods turned off, but it's actually starting about 10 years before that and continuing 10 years after that, where you're gonna have a lot of sputtering of the ovary, giving enough estrogen and not able to and giving enough. And then there's, after the periods turn off, a lot of how do I readjust with all these different levels. But if you think about people who are between 40 and 60 years old, this is the prime of their career. Their kids are out of the house. I mean, they can do stuff again. And they don't have time to deal with hot flashes, brain fog. It's not a great time to do this, if there ever was one. It's not this time of life. And then we also look around here at some of the nuances of thyroid disease. And I'll talk a little bit about that. But those are the hormone categories, the sex hormones, and then the thyroid hormones are our biggies here. So common uses where everybody knows about is oral contraceptive pills and hormone replacement after menopause. and thyroid replacement. So we all kind of know about that stuff, and that's all been in use for a long time. And the problems that most people think of when they're talking about hormones and the dangers of using hormones are the overdoses. People who are overdosing this are historically bodybuilders. They'll be on testosterone. I mean, think of Schwarzenegger or Lou Ferrigno. I mean, these people were not human looking anymore because they were overdosing themselves, and they ended up having problems with getting blood clots and having their blood be too thick and hurting their liver and and hurting their tendons because their muscles would outgrow the strength of their tendons. So overdose is the biggest problem. Very high dose oral contraceptive pills were the first pills that came out in the 60s. And if you're looking at birth control pills now, it's 20 micrograms, and then it was milligrams, and then it was 50 milligrams. This is much higher. People were getting migraines, and they were getting all sorts of weird problems. And then the other times when a lot of us may have noticed overdosing is our body naturally makes prednisone-like stuff, and that keeps a lot of stuff working for us with our glucose balance and our sodium and our blood pressure. But sometimes we get injured and we need a very high dose of this stuff to get through the inflammation of it. If anybody's blown out a disc in their back, they've probably been on a methylprednisolone dose pack, 6 pills the first day, 5, 4, 3, 2, 1. And that is a very high dose of something that your body naturally makes. So it can help you a lot with the inflammation, but it can cause a lot of confusion with the other body parts that it affects, like the blood pressure and the blood glucose. So the problems are overdosing. And this raised a lot of concerns. So it was studied. It was put into a big randomized control test. That's the standard of doing the best test. And the results were coming out in 2002. It was called the Women's Health Initiative. And there were, it turns out, a lot of problems with the Women's Health Initiative study. They were getting results from their study, and before it went to their internal review board, that information was leaked to the press, who misinterpreted it. And people sell newspapers and TV ads by frightening you and making you want to watch more about what's frightening you and how it. So they frightened a lot of people, and they frightened a lot of doctors. And a lot of us ended up making a lot of changes in practice to no longer really use estrogens and progesterones and, God forbid, testosterone, even though there used to be a really great pill, testosterone. The problems included some things. They were enrolling women who were in their 80s. Okay, if you've made it past that, really don't mess with stuff, because that's where you start getting more trouble, even if you're not on hormones. I mean, people's lifespan from 80 onward is not that long. And then they were having strokes and heart attacks and clots in their veins, but they were using horse estrogen. They weren't using human estrogen. So if you fix some of that stuff, those risks go away. So in 2009, the principal investigator for this study wrote an article for the Journal of the American Medical Association, JAMA, and went through and said, okay, here's what we actually learned from this. And it was almost like an apology letter about how this was released, because it showed that a lot of what they were doing then was misguided, misdirected, and not a proper way to look for doing replacement for hormones. So it's bad advice. And then I gave a lot of people that bad advice, because that's what we knew and that's what we did. But now we know a lot more. We've had more studies since then that have reflected the same good information from before the Women's Health Initiative. So we know that it isn't just one and maybe that's true. We've had repeated studies. Even though they're not randomized control studies, the consistent results show that getting somebody in range, not overdosing them, but in range, is very safe. So now it's different. We have bioidentical hormones. So this is humans taking human hormones, not from humans. We don't have donors. You synthesize in the lab something that looks just like the exact chemical that's in your body. That's the hormone. So it's not going to be from a horse or a pig, which is another opportunity to get hormones. There are also multiple delivery modalities. So we can go through lots of different ways of getting the hormones into you, where a lot of the problems with the liver was you would eat it and it would get in your stomach and your liver would go get it and disassemble it, and that would strain the liver. So pills are less common, and then other modalities are more common. And the other thing we learned was that starting women on hormone replacement therapy at menopause is done best if done within 10 years of the periods turning off, or the labs showing that the periods would have turned off if you still had a uterus, or if you hadn't had an ablation, or some reason why. Some people just don't get periods around that time, so they don't know if it's going to turn off. But they do know from the lab work or noticing other symptoms that it's happening. The other thing that's really important now is we know that testosterone is not a male hormone. It's an us hormone. It's everybody's hormone. In healthy, childbearing age women, they have 4 times as much testosterone as estrogen. In men, they have 10 times as much testosterone. So they're wildly different numbers, but it's so important for everyone to have the right amount of testosterone. And we make sure that people stay in the normal range. They may not be at the top of the range right now, they may be at the bottom of the range, but we may be able to bring them up to a level that makes it more like it used to be when they were 38. So they might feel more like they are 38, and their other body parts might start working like they were 38. So we keep thinking about test, treat, and check the intervention. So the results we get for the men, we have help with fatigue, stamina, strength, exercise tolerance, libido, and body fat. And in women, the skin turgor, like I was talking about with earlier, and hot flashes, women's privates work better, both ways, and sleep is better, and there's less hair loss. And then if we're looking at the thyroid part of it, the thyroid controls everything. And we check much more deeply than I do at my regular doctor's office. I do regular doctor work too. I've got a foot in both worlds. But here we get to dive a little bit deeper and do a lot more fine-tuning than what I do in my regular doctor job. But when we find something that's really out of whack with the gross tuning, that's what I need to deal with at my other job. So how do we do this here? Number one, we go over your symptoms. We have a standard quiz, and then we test the blood, and we check for levels, and we include testing for vitamins, because a lot of times your vitamins are not optimized either. This is like your B12, your vitamin D, things that are a little more subtle, but if optimized, may make everything just work a little bit better. And then we make up a plan. And then if the plan involves replacing hormones or optimizing hormones, then we have multiple ways to do it. We can use compounded creams, which has the hormone in the cream, and you rub it on a hairless part of the body, and then you let it dry. And sometimes you have to do this twice a day, sometimes once a day, and then it gets absorbed into the body. The other way is with injections, where you pinch a little bit of skin and put it right under the skin, or sometimes you have to push it into the muscle. And then regular pharmacy prescriptions, picking it up with your copay at your local favorite pharmacy. And then we also have, so that's patches and pills. And then there's my favorite, pellets. Pellets look like a little Tic Tac that we insert under the skin through a little straw in some area where there's a little bit of flesh, and then they sit there and just leach out that hormone over, in women, 3 months, and in men, 5 months. And it's made out of yams. It turns out that we have a lot in common with yams when it comes to steroids and hormones. So that's what the lab uses as a base. But it's identical to what we have. It's changed from the yam to us. Then we recheck the blood, see if we got the doses right, the timing right, the delivery right. And then we check in on symptoms too. And we are very heavy on checking the symptoms, because we know that we want to treat the patient and not treat the laboratory. So I think hormone optimization can do a lot for us. It can't save a life, but it can drastically improve a life. And I think of this as restorative. It's making you feel like you again. So that's my whole story. So I'll take a couple of questions, but I want them to be general questions, not like, I have this one weird symptom. That's more for the consult when we would talk about private things privately. But if you have broad questions about the history of the research or other things like that, I'd be glad to entertain.